So our first question here is if you all could please introduce yourselves by stating your name, your role at ODU, and if you could briefly describe your nursing experience. We're going to go ahead and begin here with Dr. Robertson-Jones.
Good afternoon, everyone. My name is Dr. Tinnikka Robertson-Jones. This is my second full official year with Old Dominion University, and I am very, very happy to be here. I have been a nurse for now 16 years. I have been in nursing education full-time for the last 6.5, 7 years, and it has been an absolute joy. Education as well as nursing are two of the things that I am most passionate about. So to be able to serve in a role that allows me to do both is truly thrilling to me. At ODU, I teach primarily solely honestly, in the undergraduate nursing department in various classes across the curriculum, and I've been enjoying that. My practice background is in cardiovascular ICU, PACU, med-surg, infectious disease. I absolutely love all aspects of nursing. I think it's just an awesome discipline with so many areas in which to venture into.
Thank you. We're going to go ahead and continue with Ms. Meeker.
Oh, hi, I'm so glad to see you guys here. I'm Ms. Meeker, and I'm actually a graduate from the ODU School of Nursing. In fact, two of your panelists were my instructors 16 years ago. So I can just vouch for what a wonderful program ODU was for me. It started my nursing career out, and I was an older student going in. I was actually in the Navy first. So my specialty is I did Mercy nursing for about 14 years. I started off with telemetry, but now my specialty is home health. So I work with patients once they get home, and it's been such a rewarding career. In fact, I think I wouldn't have been able to do it without my Mercy department experience, because now I'm at home with these patients all by myself, and it is just so rewarding to see how you can care for them now in their home. So that's a little bit about me.
Alrighty, thank you. And now to Dr. Wiles.
Hi guys, I'm Dr. Wiles. I am the undergraduate program director in the School of Nursing at ODU. I have been here since before y'all were born. That would be 1995. And done things, started as a lecturer, gone through, got my doctoral degree, did your tenure track, and I'm one of the tenured faculty. My courses that I teach here are primarily adult health. I do the role transition practicum. I lead our informatics course, and I dabble in whatever online other courses we need to do. Chanel, who is one of our people on the panel, is a doctoral student in the nurse anesthesia program. I'm her mentor as she's working on her doctoral project. So I do things in the undergraduate and the graduate program, but most of what I do is undergraduate, because that's not that I don't love you, Chanel, but I really love undergraduate nursing students and teaching people how to be nurses, which I did actually teach Chanel as an undergraduate student as well. Clinically, I have been an ER nurse for 32 years. So I do ER trauma, ICU. I still work in the ER. I still am a little bit of an ER junkie. So most of my classes start with the other day in the ER we did, or we have done this kind of stuff. I'm talking about patients. And I think that I love staying with patient care because it keeps me up to date when I'm in the ICU with students and when I'm in the ER. And I'm just a trauma junkie. And when you see me look out the window, it's because we're by the hospital, and every ambulance that goes by, I'm like a squirrel, and I'm going to watch them as they go to Centera Princess Anne.
Thank you, Dr. Wiles. And like she said, we are joined today by two of our DNP students in the nurse anesthesia program. So we're going to go ahead and ask them the same question. So we're going to start with Chanel.
Good afternoon, everyone. Again, I'm Chanel. So I'm in the Doctorate of Anesthesia program, supposed to graduate in May. I can't wait. I'm ready. It's a 3-year program. We're coming close. Like Dr. Wiles was saying, I received my undergraduate at Old Dominion back in 2011. Dr. Bennington was my teacher, Dr. Wiles, so I see a few familiar faces here. After I graduated, I went to Sentara Lee Hospital, worked in med surg there for a couple years. Then I did 3 years of travel nursing, and I loved it. I spent a year in Miami. I spent 6 months in San Antonio, 6 months in Houston. After a while, I just got tired of med surg. I was like, I want that critical thinking. So I drove from Houston, drove 2 days to come back to Virginia, and I worked in Norfolk General Burn Trauma Neuro ICU. I worked there for about 3 years. And then I decided, all right, time to step it up again and meet my challenge, which I have. And now I'm in the anesthesia program here at ODU. It's a great program. That's about it.
Thank you. And now we're going to go to Marissa, another DNP.
Hi everyone, I'm Marissa. I graduated from the University of Pittsburgh, where I got my BSN back in 2015. After that, I wanted more sunshine, so I moved down to Atlanta, Georgia, where I worked at Emory in their neuro ICU, as well as their serious communicable diseases unit, which is also known as their Ebola unit there, for 2.5 years. And then I transitioned into the anesthesia program here at ODU. And as you can see, I'm here at clinical, actually out at a rotation in Salisbury, Maryland. So I just hopped out of the OR to say hi and tell you all about anesthesia. Thank you.
Thank you. And last but not least, we have Dr. Bennington.
Hello, everyone. I've been a nurse for about 40 years, but I was, before I did that, I got my degree in chemistry, and I have no idea why. I think it was just because they said that women didn't have any business in it, and I'm kind of like, really, why not? And so I just did it. And then I don't like working in a lab. I have always helped people with giving birth, so I thought, why not go to nursing school? And I worked labor and delivery. I worked high risk pregnancy for a number of years. I've worked mother baby, and that's what I teach is the growing families, what the name of it is. And it is about preconception, conception, pregnancy, giving birth, postpartum, and the newborn.
Thank you, Dr. B. We're going to move right into our second question. We would like to hear from each of you and know what made you become a nurse. And we can start with you, Dr. Robertson-Jones, again, if you'd like.
Awesome. Why I chose to become a nurse. I have always had a before nursing, I didn't understand why. I just always asked the question, why? I always had to understand. If they were to say someone passed in a car accident, I needed to know what were the exact injuries. If someone, whatever the case, and I was at a very, very young age, and I didn't understand where that came from. And I started off in my college years, initially in the computer information systems program. And I was doing that for quite some time. I'm from Michigan, so I was working for a Ford Motor Company in the headquarters, and we went through a layoff about a year after I was there, and I was completely traumatized. I actually did enjoy my role, but I was just like, oh my goodness, what do I want to transition to now? And so I wanted to be sure that I really had a passion for patient care. So I started off initially, I did like a medical assistant program just to see that I definitely had an interest in engaging with patients. After completing that is when I first enrolled in my first program. And it was just, I had found my love. I fell in love with direct patient care. I fell in love with just figuring out my why, and I'm very grateful for that. It has truly, truly impacted every area of my life because I feel like it's just a calling. And so I have great peace, and that's why I'm so passionate about continuing to grow in nursing as well as education.
Thank you, Dr. Robertson-Jones. Ms. Meeker, are you ready?
Yes. My career in medicine actually started off with pre-med and medical school. I come from a long line of surgeons, and that's what I was supposed to be, according to my parents. And then I started pre-med and I had a family member get very ill, and I watched him in the ICU. Actually, it was my brother, and I realized that I didn't want to be a physician. And I talked to my father about it, who was a surgeon, said, would you be disappointed if I did not go to medical school? And he said, actually, I see you more as a nurse. I think that's going to bring you a lot more satisfaction, because I do love people and helping them. And but he said, but you're going to have to pay for it yourself. So that's where I ended up in the Navy for my GI Bill. But I just knew that nursing was it. I knew I wanted to be in the medical field, but there's a different role that nurses play. And I think it's just a profession that we are so blessed, and you can actually really make a difference in somebody's lives. That was the reason I became a nurse.
Thank you, Ms. Meeker. Dr. Wiles, are you ready?
Sure am. And I'm trying to think back to, I don't remember why I wanted to. There's nobody in my family healthcare but me. But I was that kid growing up. Anybody who had a boo was like, I grew up in the 60s and 70s where we didn't have helmets, where we didn't do these things. We got banged up. Like, we shot each other with BB guns and things. And anytime people were sick, they came to me for help. And I had a little file box that I had everybody's name and what I did and how I took care of them and kept it all together. I was a swimmer, I was a lifeguard. I was offered the opportunity as part of that to take a paramedic course, an EMT course, then a paramedic course in high school. And I got on that ambulance the first time and I was hooked. Just reel me in. I was there, did my undergraduate straight out of high school in nursing. Back then you couldn't go into the ER right away as a new grad. They didn't allow them. So I did a couple years on a cardiovascular telemetry surgical ICU transplant floor up in Fairfax. And then once they allowed me to go to the ER, because I'd been a nurse long enough, I went there and stayed. I'll still do critical care pieces. I love doing that. I did that as part of my graduate degree. But you know what? I'm an ER junkie. And once I did that first ride on the ambulance for that first thing, there was no going back. I think I have that blend of OCD that you need to be a good organized nurse, but ADHD, because you have to have that to jump from thing to thing to thing in the ER.
Thank you, Dr. Wiles. Chanel, are you ready?
Why I became a nurse. So I'll split it up and say exactly why I became a nurse, and then I'll go into anesthesia aspect of it. I just love caring for people. I love taking care of people, and I actually love the human body as well. I have two of my aunts are nurses, and I spoke with them growing up, and I was like, I really like what you do. And plus, once you have that RN, BSN behind your name, you can do so many things after that. So I figured, hey, if I don't like bedside, I can do this, I can do this, I can do this. There's so many opportunities within nursing. Onto anesthesia, I really just wanted that challenge. I love taking care of critically ill patients. I love knowing exactly what's going on with them, how to treat it, my medications that I'm giving to them. I want to know how they're working down to the cellular level, and I want to make that difference in somebody's lives. I just love caring for people in their most vulnerable states. When you're coming in for surgery, you are nervous. So I want that responsibility. I want to be able to take care of somebody safely in the operating room. So it's me.
Thank you, Chanel. Marissa, are you ready?
Yeah, so I grew up in a very heavily medical family, and my experience, I kind of always knew I wanted to go into medicine. I didn't really know what my role would be. And I went to Ocean Lakes in the math and science program there. And to graduate, you had to shadow someone in a field that pertained to math or science or complete a research project. So I actually shadowed a nurse anesthetist, and I spent in high school 100 hours with her. And there is nothing that can beat any form of shadow experience in verifying where you want to be in life. And that kind of helped steer me clear from med school and helped just reroute my path into nursing and helped me find my foundation there.
Thank you, Marissa. Dr. B, are you ready?
Yes. As I said before, I got my first degree in chemistry primarily because they said that women had no business in it. And a friend of mine and I kind of like, why not? And then once we finished, we realized that we didn't like working in a lab. So I ended up teaching a chemistry for the health sciences class in Florida for Daytona Beach Community College, and got to know a lot of the nurses. A lot of the nurses took my class. And actually, I had 2 children down there. I did not like the way I was treated during my labor and delivery, needless to say. Got involved with some women there who had a movement to change childbirth. And then my husband got a job teaching at ODU, and we came up here. I thought, maybe I'll go to nursing school. Maybe I can get involved with it. So that's what I did. And I, once I graduated, it was like Dr. Wiles said, they wouldn't let you go into labor and delivery first at that time. They do now. So I had to work a year on med-surg to start with. I did not like it. I was anxious to get off it. And I knew they didn't like to take you in labor and delivery. And by that time I had 4 children. And so I kept bugging the nurse manager, you're going to get an opening, can I please? And she don't have any experience. I said, I had 4 kids, isn't that enough? And so finally, when she had an opening, she remembered that I had been bugging her all the time. So she interviewed me for it. And that's when I first started working in it. And then it just went on, and I got my master's and got my doctorate degree after I started teaching at ODU. And I love it. I would never work in a lab again.
Thank you all for your responses. So the students, you all can see that there's a bunch of reasons that somebody can go into nursing, but the passion is still the same. And moving on to our third question, could you walk us through a day in the life of being a nurse in your specific specialty and your responsibilities? So we're gonna go ahead and start at the top again with Dr. Robertson-Jones, whenever you're ready.
I guess I would go with my most recent practice. Currently, I'm not in a role of direct patient care. I'm working as a professional development coordinator with the Bon Secours health system. And that role entails really working with a lot of the onboarding of the new hires, ongoing competencies and things of that nature. In the ICU, of course, it was vastly different, and I really, really enjoyed that role. The day was quite busy. No day was like another. So you really didn't know what you were going to see, what you were going to get. The patient acuity level was extremely high. What I really appreciated was my team. We had a great collaborative work ethic in that department, and you really need that. And I really encourage students even today that they oftentimes are quite anxious or quite concerned about their transition into independent practice, but for all intents and purposes, you're really never alone. And it's really important to, have a good working relationship with the individuals that you work with, and also be the type of team member that you would be proud to work alongside of. And so we really emphasize that. A day was, starting off the morning was typically the busy. I primarily work days, and I know it's quite different if you work off shifts, but I primarily work days throughout my nursing career, my direct patient care nursing career. And days was extremely busy. We do a lot of collaborative rounding. I work for a teaching hospital, and I know that will vary depending upon the type of health system that you work with. I primarily work with teaching hospitals. I really enjoyed that. And so we start off really getting to know our patients at the start of our shifts. We did bedside rounding even then, which is highly encouraged today, to ensure continuity between the handoff and what you're going to be assuming responsibility of for your day. And I wanted to get in and get my assessments done on my patients right away and establish a therapeutic relationship with them for working with them throughout my shift. And then, of course, medications and therapies and things of that nature. My days were much longer, oftentimes than 12 hours, just kind of staying behind, helping out, charting, because of the acuity, we may have emergent situations that were to arise. Our team was really good at supporting one another throughout those various transitions. So it's something that I really love, and I miss often time to time, but I really love serving in the capacity that I'm currently serving in as well.
Thank you. And now we're going to go ahead and popcorn over to Ms. Meeker.
Okay, typical day. With home health, I thought I'd never become a home health nurse. I thought it was going to be the most boring job I'd ever have with patient care. Like Dr. Wiles said, I was in love with the ER nursing, being in the ED. I loved this thrill of not knowing what was coming in. But there comes a point to where you have to make changes sometimes. And I decided to try home health. And I'm telling you, it's probably been the most amazing job I've ever had. you never know what you're walking into, and you are walking into homes of people. They're inviting you into their homes, and you don't know what you're going to find. There are plenty of days that I've had to call 911 right away, or I am the only person that has found this person on a floor when they weren't answering the front door. And I never thought that I'd ever say that I thought I saved a life by home health nursing, but I feel that every time I go in. The amount of education. So my typical day is I get an assignment for a patient that that has just been discharged from a hospital, and some of them are in critical care still, because when the hospitals are overloaded, they discharge them home very early. So I walk in and I'm their case manager, and I decide whether they're going to need physical therapy, occupational therapy, nursing, speech therapy, medical social worker, or sometimes I have to call adult protective service. When I go into the homes and see what I'm assessing. It really takes a good assessment and a good knowledge of critical thinking and what you're looking for, because you're the only thing that doctor is relying on to see how their patient is doing in their home. And there have been some very scary situations for me where I've walked in and I've had to perform CPR, I've had to call 911. It is the most exciting nursing job I think I've had. It's right up there with being in the emergency department. And the other side of it that I love is just talking to the patients and educating them. And when you find yourself in the hospital, a lot of us are upset because we can't educate. We are so busy with everything that's required of us that we don't get the time to sit down with our patients. And with home health, I have all the time in the world. I go through their medications. I educate them on preventative measures. I call their doctors for them. I set up their appointments for them. And it really gives you time to really get to know the patients and their families. So my day is different every time I walk into the houses. And I also work in the facilities. So I also can go in the nursing homes when they have no visitors and talk to them and play checkers with them and spend the day with them. And it's so rewarding. So I really enjoy it.
Thank you. And now we're going to go ahead and move on to Dr. Wiles.
So I love 3 to 11 and I love night shift. So to me, 5 o'clock in the morning to get up is like the worst thing that happens. So when you are an ER person, you know, the people who go in at 7, you get a little bit awake, but when you go in at 11 a.m. or 3 p.m., you need to just have your skates on and ready to roll, because you are going to get your butt kicked from the time you roll into that hospital until the time you leave that hospital. So I love that. So where my typical day is going to depend on what part of the ER I'm in. Our ER, one day you may be in the psych pod taking care of all psych patients. One day you may be in GYN sections. One day you may be in the trauma beds. One day you be in the critical care beds. One day you might be in med surg. Another day you might be in fast track or focus care. So I love the variety of where I go in and what I do. You know, it drives all the floor nurses crazy, and especially the ICU nurses crazy. I can do an entire shift change report for all of my beds and not write a thing down. Okay, you know, ICU nurses are writing breath sounds, lung sounds. No, look at the chart. No, so I mean, our ER report is different than anybody else's report. I want to know, what do I need to do next and who's going to die? Okay, so, and not all the details. And then I listen to what my patients are and I see who I need to go. Or there might be somebody I need to go see, but there's an ambulance coming in the door and we've got to go get that person off the stretcher. So it is definitely, you may have this great idea of all the things you're going to do, and then something happens to somebody else and we need to jump in. So it's the ability to switch gears. The pieces I love about the ER, I love the collegiality we have with our providers. We talk to our docs on a first name basis. We go in there, we have a lot of protocols, so there's a lot of autonomy in there. And as you've been doing this for, you know, a few years, you get mutual respect from them, and they know what you can do, you know what you can do. So we do a lot of things playing detective. I love going in there and figuring out, all right, these people come in with these symptoms. We're trying to figure out what's going to kill them, make sure it's not going to kill them, and then go to, okay, what might the other things be? And I love looking at chest x-rays and just talking to providers and doing that intercollaborative, interdisciplinary kind of thing as we run around like crazy people. Take your lunch with you, because you're not ever going to go to the cafeteria and go get food there. Just kind of fun difference, but you have to be able to balance, because you're going to go from somebody who truly doesn't need to be in the ER, who's there because it's raining, to a very sick baby, to somebody who's old, to somebody who's young. So it is more of a challenging place for new grads to go if you haven't done some ER, some tech, some EMS experience, because you have to know a little bit about everything. You can birth a baby, you can hold a hand, and you have to be able to go all over the place and prioritize. But I love the chaos, and I love the fact that my day changes based on which part of the ER I'm going to be in.
May I add to Lynn's? I think for you to be a good home health nurse, you need to be a good emergency department nurse, because as she said, it's a lot of autonomy. And I don't think I could have been as good of a home health nurse without my ED experience, because we actually write the physician orders and send them to the physician to sign. So we were actually writing medical orders for the doctor to sign off, because he can't see the patient, we can. So I thank my ED, well, actually I thank Dr. Wiles for getting me into the emergency department and getting those skills needed, because once you have those critical thinking skills down, you can go anywhere.
Thank you. And now Chanel, whenever you're ready.
Yes, I'm ready. So before I start off, I wanted to talk about the actual anesthesia program, because anesthesia school is my life right now. So a day in my life is anesthesia school. It is a 3-year program. I see you laughing, Marissa. She knows. It is a 3-year program. The whole first year is all butts and seats, didactic classes. You're sitting in the classroom, you're learning about the basics of anesthesia, the principles of anesthesia, your pharmacology. Of course, you have some ethics and research classes involved. The first semester of your second year, you start to ease into clinical. That's usually the scariest moment of your life, because now you're not touching mannequins anymore, you're touching human beings. Once you get over that speed bump, you're pretty much sailing after that. You start off with 2 days a week in clinical for your first semester, and then you go on to 4 days a week after that for the rest of the program. We spend up to 40 hours a week in the operating room, sometimes more actually. Since COVID hit, we've been a little bit behind, so we've been having to make up a lot more hours. Within those clinical periods, every month you usually go to a different hospital. We have different specialties. You have your cardiac rotation, you have your pediatric rotation, your OB, your regional, your trauma rotation, and then in the mix between there, you have your general anesthesia rotations. I'm currently going into my trauma rotation starting Saturday night. So I'm just jumping right into the deep end right there, you know, and Marissa is on her specialty rotation right now as well. So that's pretty much how it goes. You spend a lot of time in the operating room, which is fine. I love the hands-on aspect of it. Wasn't really a fan
Chanel,
of the
you got to say it's Saturday night in Jersey, right outside of New York City.
Actually, I go there. Yeah, wait, so, we also have out-of-state rotations as well. I start on Saturday at Norfolk General nights. And then in November, I go to New Jersey and Newark, New Jersey, and do night rotations over there. We have a rotation in Oklahoma. Marissa's in Salisbury now. We have, you do your pediatric rotation either at CHKD or you go to Nationwide Hospital in Columbus, Ohio. So our class is kind of split. So actually, there was a period where I didn't see any of my classmates for about 5 months. You know, there's some of my classmates that were away for 6 months at a time. And, you know, you don't have to worry about paying for anything out of pocket, by the way. The school will provide that. So everything is set up in that aspect. But it's fun, though. You're definitely independent. So you will go to clinical sites by yourself and you'll be just fine with it. It's going to be scary at first, but, you know, you have the CRNAs there, you have the knowledge. You just go there and do what you have to do. You know, we're making it. We're still smiling. I may have a gray hair too, but that's it. I'm good. You know. So Marissa, did you want to talk about a day in anesthesia world when you go into clinical? Since I did all the talking.
I'll chime in. So for us as well as providers, once you're on your own, a typical morning, you would show up similar as you would for a regular shift early in the morning. You would go into your OR that you're assigned to, depending upon what types of cases you have, it would be in a different area. You do a machine check, set up your airway equipment, set up your drugs, and your setup would obviously differ depending upon the case that you would do. And I mean, we do all of the cases. So that could be orthopedic surgery, ENT, neurosurgery, vascular surgery, gyne, OB, like cesarean sections, placing epidurals. We're trained to do it all, which is kind of the beauty of moving on in a field of nursing, because in nursing you can do anything, but then when you move on to anesthesia, you kind of still have that benefit. So after setting up your room, you go and you see your patient. And I think a stereotype of anesthesia is everyone that goes into anesthesia just puts their patients to sleep. They're not very social, but there's so many social aspects of being in anesthesia too, like getting all of the information about your patient in the morning during a thorough pre-health assessment, PrEP assessment, excuse me, or maybe coaching a mom through an epidural that's laboring and that's really uncomfortable. So then from, let's say, after our pre-op assessment, we bring the patient back. We coordinate with our colleagues, the physician anesthesiologists, to help put the patient to sleep, depending upon the facility that you work at, the type of care team model that they have there, or if you work in maybe more of an independent practice, you might be the only provider putting your patient to sleep and using the resources you have there. So guiding the patient through the different parts of your anesthetic, so the preoperative period, and then bring them back to the OR, putting them to sleep, however your plan is, and then maintaining them through that plane of anesthesia through maintenance and waking them up and bringing them to recovery. And the most rewarding thing is having a patient wake up and smile at you, and you ask them if they're in pain, and they say no, and they snooze back off to sleep.
Ask you, are we done yet? Are we finished? Those are the best.
Yeah, so we get to work in a lot of different environments. We get trained in all sorts of environments. I'm here for my cardiac surgery rotation now, as well as regional blocks. So we're trained to place regional blocks as well to assist in orthopedic surgeries and other types of surgeries. So the opportunities are limitless.
Just to piggyback on that, waking up super early in the morning, we're usually at the hospital between 5:30 and 6 in the morning for a 7:30 case. I have worked nights my entire nursing career. Straight out of nursing school, I went straight to nights because I am not a morning person. And I think I've grown up now and I've become an adult, and now I'm a morning person. Can't say I really like it that much, but yes, I do wake up super early in the morning. So I know if I can do it, you guys can do it for sure.
Thank you both. That was a lot of good information. And lastly, Dr. B, can you tell us about the day in the life for you?
Well, it's been very interesting recently. I wasn't quite sure how we were going to be able to do our rotation. But once we got there, it's really funny to me. I guess a lot of people have no clue what goes on in L&D and mother baby, because my students have gone, oh my God, I didn't know it was going to be like this, because kind of like Dr. Wiles described it sometimes. One of my students on our first day, when we finally got back into clinicals, they had to do a C-section and the baby coded immediately, and they were just like getting out of the way. They said, I've never seen such teamwork. Everybody got together, they were doing all these things. And then a couple of weeks ago, we had our day started off with having a woman walk in with a lot of pain and bleeding. Turned out she had had a complete abruption. The baby had died. And they came up and told me, and I asked my students, I said, this could be a difficult decision for you. Does anybody want to take care of a woman whose baby has already died? You want to know what that's like? And because a lot of times they don't want to, and especially maybe not on their first day, although I've had other students have to do it too. But it turned out that we thought she was going to be able to deliver vaginally, but then she started hemorrhaging. And she probably was already in DIC when she came in. She was hypertensive, had a normal blood pressure when she arrived, which probably meant that she was already bleeding out because she was very hypertensive and had not been on any of her medicines. And she ended up in the OR for about 4 hours because we ended up having to do a mass transfusion and do a hysterectomy. And it was interesting because I really admired my students that day. The one person who did take her completed the day with learning. She had to go to ICU, but she completed the day by learning how to prepare a fetal demise. The baby was a fresh demise too. So it didn't look emaciated or anything. They cleaned the baby up and then took the baby to ICU so she could bond with it. It was quite an interesting day. And none of my students were anywhere to be found for post-conference. I went out looking for them. And we always say L&D is like a feast or a famine, but most of the time it seems to be a feast these days. So I went out looking for them. And just prior to that, I had heard a midwife say, well, we have a patient come in, and she said something about the baby being way up in the abdomen, but the woman's cervix was opened and stretchy. And I said, well, I hope her membranes don't rupture. And I walk out down the hall and I see a bed go flying by with people in the bed with her, and we had a cord prolapse. So that was an immediate emergency C-section. So that was a very busy day. And needless to say, we had some babies that did end up in the special care nursery as well. And when I finally got them all together for post-conference, they were like, oh my God, I didn't know L&D could be like this. So Shavae was with me on one of them. I don't think that was was that one of your days with me?
No, but we had a good day when I was there too, so I can attest to that.
I know, I've had some really crazy days recently, but all of them came out and said, I had no idea that OB could be like this, right? And you never know what's going to happen. We have sometimes what they call stop and drops, where they come in and they're ready to have the baby right then. I can usually spot them when they get off the elevator. I've been in the field long enough. I see them by the way they're walking or sitting. I go, she's ready to deliver, right? So it's very interesting. It's always a busy day. You run constantly. And it can be very exciting. It can also be very sad. So it goes the depth of emotions.
Thank you, Dr. B. Our next question is very relevant to what's going on in the world right now. We would like to know how COVID has impacted your nursing experience currently. We can start with you, Dr. Tinnikka Robertson.
For me, it's greatly affected both roles, definitely as an educator as well as in my role with Bonds Course. So as a professional development coordinator, our role really is based on providing the support for the current nursing workforce within the system. And with COVID, it required so much education on how to care for the COVID patients. So we really had to, and it was a moving target, we really had to, as Dr. Wiles often says, remain fluid in regards to, as information was coming out, sometimes several times a day, we had to continue to update our practices in regards to how we manage the care, how we organize staffing where that's concerned. And it was very challenging. Staffing was definitely a challenge because of departments that were really heavy, and then some were a little bit short where people were scared to come into the hospital. So it required a lot of support for the staff in a lot of different ways. Some of that was just even emotional and mental support because there was a lot of role strain, particularly during those really high intensity months early on in the outbreak. And from an educator standpoint, it was a challenge for us. And I think all of my colleagues can attest in terms of clinical sites and limitations where we were kind of removed from a lot of the settings for protecting everyone for COVID. So that became a challenge in facilitating the courses and trying to essentially allow students to get that clinical practice and shifting a lot of classes that were face-to-face to online and condensing some of those time frames as well. So it was definitely a challenge, as I know it has been for everyone, but I'm thankful that, we are, fingers crossed, kind of holding steady and able to kind of get back to some sense of normalcy. It's not nearly the same as it was before, but we're definitely back in the hospital settings, and that's been wonderful.
Thank you for sharing. Ms. Meeker?
I'm not going to talk about the effect as a faculty member because I think we all are dealing with the change in how we instruct. If we're going to talk about faculty, I think the biggest difference I have seen is I think it's very hard to lecture to masks and all you see is eyeballs. And I can't really read students as well as I used to. But for home health, it's made a huge change. It used to be difficult to go into houses because, you know, a lot of people do not have air conditioning. A lot of people do not have, I mean, the very unsanitary conditions, and now add on 3 layers of PPE and a 2-hour visit into a home that has no AC during summertime. It's very difficult. In fact, we've had a lot of clinicians that have actually passed out on the job and had to be taken in for dehydration and heat exhaustion. So it does make our job difficult when we go into homes. The other aspect is it makes it very difficult because now you're responsible for your equipment and your, you know, how you're washing your hands, because I think any of us that would bring in COVID to an elderly's home or a facility would never forgive themselves if they were carriers and did not realize it. So we have to be very careful when we go into people's homes, and the facilities are all locked down. So we actually have to go through a huge screening process and get permission. There are some facilities that are not allowing home health in, but the only time we can get in is if it's a wound care that cannot be done by staff. So they'll let us in for Foley care or wound care, but a lot of times we're not allowed in. So this has been a new world. At the same time, it has been wonderful because there are things we can do for these patients and facilities that can make a life-changing event for them. I went in with my phone and FaceTimed with an elderly's family member who they haven't seen in months because they do have a little bit of Alzheimer's or dementia. They do not know how to use a phone, but I was able to actually pull up their family member on the phone so they could see their loved ones. And that made all the difference in the world to some patients. So there's some positive that come out of it.
Thank you, Ms. Meeker. Dr. Wiles?
I think that at the beginning, you could only describe the ER as a hot dang mess. Okay, so infection control is the opposite of the criminal justice system, and you are guilty until proven innocent. So you come in and we are expecting that you are COVID positive and treating you like you are COVID positive because we have to still be able to go home at night. I think the biggest change, and everybody who's working clinically would agree with, that actually drives me crazy, is everything we've ever known or done about infection control based on evidence-based practice has completely been shot out that window, stomped on, squished up, rolled in a ball, and tossed in the trash. For example, PPE. Prior to March of 2020, you went into a patient's isolation room, you took off your gown, everything in the room, balled it up, and God forbid you walked outside of the room with your gloves or your gown on. The infection control people were crawling up your butt to yell at you. Well, now we have a lovely little stack of command strips outside the door. And when I walk out of that room, I take off my infection control gown, hopefully don't get it on my face, which does have a mask and a shield, hang it up on the outside of the door. And then the next time I go in, I put on the same gown and I take it off for the entire time I'm there. The mask that used to be single mask that I only went into a room, I'm now in Shavae's room and Ariana's room and Leanne's room and Linda's room and Marissa's room and Andrew's rooms and Jacob's room and Amy's and Tinnikka, all in and out of the room with my same mask on my face every day. Oh, and anything about privacy, that has completely gone out the door too, because if you're COVID positive, on the wall of your door, you now have in like the biggest little dry erase marker, respiratory isolation, not to mention the fact that you have 37 gowns outside your door. So there have definitely been some pieces I worry about from a healthcare standpoint, about our safety and our health. I worry about what I'm taking in and out of patients' rooms. We've done a very definite change. We no longer give, people who are asthmatic who got nebulizers. We can't do that anymore because it aerosolizes in the room. So we only use that for people who are really sick, and you have to do an N95. So now instead of a handheld neb, you get 6 puffs of an inhaler. And then one day, the day that did completely freak me out, I had a little temper tantrum. They said, oh, it's okay to use inhalers between patients as long as you use a spacer because we've run out. And if you have a spacer, they aren't actually breathing the same thing. So there was a short little policy time that it was going to be okay for all of us to just share our asthma inhalers. So the biggest thing for COVID, besides, there's definitely been the emotional part, the part for families can't be there. You're not with your family in the ER, nobody in the waiting room. There's quiet in the waiting room because you come back into a room. It's very frustrating for patients. It's very frustrating for staff. because families can't be there. It's hard when we have that code that you have to go. At the beginning, we had a code that we went out to the parking lot to the family's car to let them know that somebody had died, because we couldn't let them come in because their patient was known COVID positive. So it has changed so much of what we do. Some of the things will probably make us more streamlined. Hopefully we become more reliant on ourselves to be able to do PPE than other countries. But I really do want to get back to the day of proven infection control and not shared gowns and not shared masks. And, you know, like you said, we aren't even going to go into clinical and teaching, because that was a nightmare. And I do agree that I hate teaching in my mask, looking at you guys in your masks, trying to figure out who you are when all I can see is this much of you every day. And I may or may not have answered the question, because quite honestly, I forgot the question.
You did fine, Dr. Wiles, you did fine. Nurse anesthesia students, do you have anything to add about how COVID has impacted you?
Yes, it is. It's different for every hospital. Just anesthesia in itself we're all about protection, protection, protection. I don't think you can get any closer to COVID than actually intubating the patient. I mean, you are literally in their airway, you know, so most hospitals test their patients when they're coming in for elective surgery, and we have the results available prior to coming into the operating room. Some patients are not tested at all. Again, facilities are different, but most of the time we just treat them as if they do have COVID, you know? We have our N95 mask on, especially when we're intubating, and we usually have a mask over that to protect it, because we are, like Dr. Wiles said, we are reusing our mask. So we have to put the other mask on top of it. We do have our eye protective, our glasses on as well, and some people actually have shields on. So we use a special filter on our circuit, especially for patients that we know for sure are COVID positive. We have special filters there to protect anyone else in the room. Some facilities, once anesthesia actually intubates the patient, everyone else in the operating room, the surgeon, the surgical assistants, the surgical techs, can't come into the room for another 20 minutes. Again, they're saying that it takes about 20 minutes for the air to transfer out of the room and circulate. Like I said, every hospital is different. This is the hospital I just came from. They were the only ones that did that there. Maybe Marissa can speak on that, but it is hard for us students going into it, because we're going from one facility to the next and we don't know their protocol. Sometimes they don't know their protocol. It's changing every day. So it is tough. But the main thing is just protection. We change our techniques. Specifically when I'm extubating the patient, I like to put a towel around that area when I'm extubating them, taking the tube out to make sure, to make sure there's no saliva, no aerosol going out. I just not only protecting myself, but protecting everyone else in the room as well. And I think as anesthesia providers, that is our responsibility to do that.
Yeah, so chiming into that, so speaking about our profession first, so when COVID first happened back in March, a lot of anesthesia is centered around elective cases, right? So when COVID hit, a lot of facilities were hit really hard, to the point where elective cases were canceled entirely. So a lot of CRNAs in our profession were either furloughed or were asked to step up and intubate patients in the ICU, because as airway experts, this is what we're trained to do. So a lot of CRNAs, I've been sent to all the away rotations. So a lot of the CRNAs that I've communicated with, they stepped up and functioned as essentially as like a nurse practitioner would in the ICU, to assist the teams there and assist with intubation, central lines, that sort of thing. As far as us, as students, what happened with us being in anesthesia school during COVID, we were displaced from clinical for anywhere between like 2 months to 3 months. Everyone was a little bit different. And I'm at a site now with students from different schools, and this is their first time being back in clinical since March. So for us, we still have May graduation on our minds. We're in clinical hustling, making up overtime hours. We're working the late shift, the weekend shift, all the shifts. So just kind of stepping up to assist. And I mean, us as students too, while we were displaced, we were still in classes, and we were asked actually as students with prior ICU experience to assist nurses didn't have ICU experience, as far as educating them on the different drips that we use every day to we came together, we made a presentation to assist nurses to help understand our vasopressors that we use for hemodynamic support, kind of giving back to help the community, since the need for critical care support nationwide like tripled in a matter of weeks. So, I mean, giving back and understanding that we play a critical role in this pandemic too.
Thank you. Dr. B, do you have anything to add?
It's very confusing in L&D because they're sort of like known status or unknown status. And so that kind of determined what my students could wear. If it was an unknown status, I'd give an N95 to wear. And if they were known status, and we knew that they were, when it first happened, L&D got very, very strict. They wouldn't even let the woman's significant other come in with her. She had to come in and labor alone. And then that changed because there was a bit of rebellion from people about that. What happened then was doulas were not allowed to be with them. And so virtual doula assisting started happening. And they were doing FaceTiming and helping out that way. And now what I'm seeing in our rotation is pretty much everybody's coming in to visit. And I'm kind of like, I honestly don't know what the policies might be in OB. And what goes on in OB also seems very controversial because some literature says they're very susceptible and other literature says they're not. One piece that happened initially was the NICUs almost cleaned out. There were almost no babies in NICU. And they're like, what happened? That they're not, people aren't delivering preterm? Why? I thought, well, maybe it's because they've been put off work and they have to stay home, so they have less stress in their lives. It's very confusing. I feel like, I know how it is probably, like you say, with OR and the ED thing, but I just feel like sometimes in OB, we're just kind of making a snap decision at the moment on whenever somebody walks in and we don't have time to find out anything about them. I'm sure that's true in ED too. So, but you're always prepared to say you're going to just prepare and assume they are, right? And with us, if they've been at home the whole time, and then some of the nurses are saying, oh, they were scheduled C-section and they got tested 3 days ago. Well, what have they been doing in the past 3 days, right? So it has just really been crazy. Mm-hmm. And I just kind of we're very fluid, as Dr. Wiles always said. The students, I'm just like, they go, well, what about this? I said, do what your nurse tells you. Right? So I'm sure they may not know what's going on either. So it's an interesting area to be in because I know at our faculty meeting, and I was hearing all the rules and regulations, I'm like, gee, we didn't do that in OB. Right? And I'm sure you didn't in ED either. Right? I know. So I am just kind of always confused because some literature says that pregnant women, it's worse for pregnant women, and other people say, no, it's not. And I don't think they know, is basically the whole thing. And the other thing is, of course, the virus I read just mutated again last week. So who knows? It's crazy.
We must be fluid because flexible is too rigid. How many times have we said that since March? We must be fluid because flexible is too rigid.
And that is the nursing student motto right now.
It is. And so ED and OB, we're very fluid. And I'm sure OR is too, right? Because you don't know either, right? So yeah, we have to be. Okay.
Yes, you should see the trunk of my car. I have bins with a small ER in my car because you don't know what to expect. So it's there. So if anybody gets hurt and I'm parked in the parking lot, just come get me because I have every medical thing that you need ever in my car. So
I think one other thing to add for everybody for COVID, whether you're a nurse or not, one of the other things big change for me is the amount of clothes I take to work. when we first started doing this, I went to work in scrubs. Before I left the ER, I took off my scrubs with my shirt like that so it doesn't go across my face, and put on and I had underneath of it a pair of tank tops and a little pair of shorts. And then I put on a pair of sweatpants and a shirt to get to my car. And then I didn't want what had now been in the ER through the ER getting in my car. So in my car, I had a different sweatshirt, and I would take everything off. I put all of my clothes in a bag, including my shoes in a separate bag. And when I went home, everything went straight in the washing machine. I went up the back stairs. Everybody knows when mom comes home from the ER, just get away from the back stairs, because I'm streaking from the back stairs to the shower. But my shoes never went in the car. My clothes never went in the car. My coat never went over my clothes that I wore with patients. And I did 2 clothing changes to get in my car, had a pair of flip-flops in my car to drive home and get in the house, because my big thing was trying not to take it home to my family. My kid was sent home from school just like everybody else was in the spring. I have a mom who's almost 80 with some different, medical things. So it was the amount of clothing that you changed to get out of work. Did you guys, do that, in the OR? You guys putting on scrubs in the OR anyway. But my pair of scrubs that I wear, and when this is all over, I'm going to need some new ones, because mine all have bleach splashes all over them now from the amount of bleach on washcloths that we're wiping everything down. So ignore my navy blue with my little pink and purple splotches.
That's a good point, because I have to change scrubs between each household. And so where I used to be able to put a set of scrubs on and go see 3 patients in 3 homes, I now have to change. And honestly, to find a place to change on the road, especially when you walk into a grocery store with scrubs on and everybody wants to shoot you, it is just, I have to sneak in the bathrooms. And I know they're looking at me with my scrubs, but I can't afford to drive to a patient's home, come home, shower and change, and then go to another patient's home. I actually have to find places where I can go in and change in their restrooms. So I have a fresh pair of scrubs, shoes, socks into each patient house I go into.
Well, thank you all for this information. I'm sure it was really informational and helpful for our students. Our last thing is just if anybody has anything that they'd like to add or say, any of our panelists.
Sure, I'll chime in. My best advice for all of you, especially as you're just entering the world of nursing, is to just kind of be a sponge, I mean, get out there, and everyone that you interact with is potentially a future mentor, right? Every experience that you have could be a moment that is going to be it for you, that's going to decide, yeah, I really like this, or I don't really like that. In nursing school, you're going to be exposed to everything. And I mean, don't be afraid to get like a tech job where, I mean, you're building upon the skill set that you're just starting with, so get out there, ask good questions, and any question is a good question. Anyone that makes you feel differently, then ask someone else, and just get out there. And I mean, the beauty of nursing is that you don't have to stick in one specialty, right? And there are different roles in nursing that allow you to be so flexible that you can do a little bit of everything. So being here is the best decision, just listening, and just keep doing what you're doing.
Thank you, Marissa, for closing us out. I just wanted to say thank you for all of our panelists for coming and sharing their wealth of knowledge with us today. And thank you, students, for coming to participate. And I hope everybody has a great day.